The time they arrived, he was aphasic, with right hemiplegia developing before their eyes. So clearly this was all happening, very hyperacutely, and he appeared to be having a visual defect on the right side as well, and leftward gaze deviation. So the only number here that now that we're in a situation where oil prices are down, we're a bit cost constrained, we might be threatening a change in services. We have to remember that the cost to Alberta of stroke is probably 300 to 400 million per year. And that's in direct and indirect costs, all right? So I think it's really, really important to keep that in mind. The average cost at a year for a single patient is 80,000 to 100,000, and probably 40,000 at 6 months. So there's a big cost to the disease, so we still need to do this stuff to improve the quality of treatment and maximize the value of our treatments. And we made a lot of progress on the provincial stroke strategy, increasing the number of centers across the province that could give clot-busting drugs, which you all know about. But what we struggled with, of course, was the purple line here, which is door-to-needle times for stroke, which we really had a tough time getting under 60 minutes. And even after 2011, where this graph leaves off, it probably went up higher still after that across the province, which is why quicker is so important, and it gives you the history of just how effective quicker has been, because we now have an unheard of drop in door-to-needle times. So I bring you back to this graph that I like to present, which is the timelines in TPA use. And basically, the CT scan is a major factor which can sometimes introduce delay, because it's an essential part of the process that you can't do without. And of course, if you spend extra time on every step, you can prolong door-to-needle times by 90 minutes in a tertiary care center, and the same situation in a rural center where you have the same number of steps, but just different kinds of steps. Okay, you have telehealth and video conferences, whereas in a tertiary care center, you have a stroke fellow calling their attending physician, but there's a lot of stuff that's the same. And in case you are new to the collaborative, you can't get by without a CT scan, because although this is a subarachnoid hemorrhage from a ruptured aneurysm, you can usually tell this clinically from a stroke. Nobody can tell this thalamic hemorrhage from an ischemic stroke syndrome. All right, so the CT scan will always be an essential part of the acute thrombolysis process. So you've done your CT scan, and as we've talked about before, it isn't enough just to do the scan there. It does have to be pushed to the telestroke neurologist. And so we've talked previously about how to do that, and it is really important that we get those plane scans first, all right, that we get the plane axials first. The axials are the ones that we use most. Those need to go through, because it'll take those anywhere from usually 3 to 7 minutes, sometimes longer, to go through the internet to actually get to the impact server where I can see them. All right, so if you bundle it all, if you wait till the CT angio is done, there may be delay. And if you bundle all the films together in a massive CT angio file, it actually may take a lot longer for that massive file to make its way through the system. All right, so those first plane axials are really, really important. And of course, the CT angiogram, all right? The CTA speed's highly center dependent, but as Michael has said before, and as we've put in the algorithm, ideally the first scan is a CT scan plus a CT angiogram, all right, almost always. If you can do it within minutes, and that's your metric. If I can do a CT followed by a CT angio within minutes, it makes a lot of sense. And the reason is because by the time those images get to me, the plane scans get to me, and I look at them, it's at least 5 minutes. And you can do a CT angiogram in 5 minutes if you're fairly quick, all right? So that's what we actually advocate, that both are done with the first imaging modality. So I'm going to structure the rest of the talk into questions, and we're going to go through the questions to see if we can answer some of them. So the first question is, when do I let CT know about an acute stroke? So when should that happen? And the answer, does anyone have any suggestions? As soon as possible, right? Absolutely. ASAP. Because they'll be able to schedule. They appreciate that. They appreciate knowing as soon as possible about the patient, because they can schedule the patient in amongst other patients. And it's the same thing probably in Foothills and at the University Hospital and at the Grey Nuns. With pre-hospital notification ideally, which most of you guys now have down to a science, but just to formalize it, ideally if you've got a callback situation after hours, you want to let your CT tech know as soon as you have pre-hospital notification. And then again, as soon as the patient arrives in the ED, because once they've arrived, they're going to be scanning within minutes, so they need to organize themselves ASAP. Especially if you're at the Grey Nuns or the U, or maybe, maybe in Red Deer and Grand Prairie, where the CT scanner might be used for other patients or a trauma or something else. If you let them know again ASAP, don't just leave it at the pre-hospital. They'll be able to organize themselves to be able to scan your patient as quickly as possible. All right. All right. So the next thing is, where are we here? Yeah, so if you can't actually notify with pre-hospital, then failing that, you need to have multiple steps where you've checked to see if CT's been notified. And if they haven't, then you notify them again at that step, okay? And the patient arrival is really, really about as late as it gets. All right, so Steve arrives at a primary stroke center where the in-house technologist can do a plain CT scan. There's a callback needed for a CTA technologist. Since CT plus CTA is the new standard, do we wait for the CTA tech to arrive before proceeding with both? So the nice thing about this talk is we've answered all the questions now, which is great. It's review, right, as part of the previous discussions that just happened kind of on a random basis. All right? So yeah, so it's good to review it, and the answer is, probably not. All right? And so in regards to, so the answer to that last question is, you do the plain CT scan immediately, if you can, and then you do a callback. And as soon as the CT tech comes in, that's when you do the CT angio, okay? And then we'll work on the so-called red referral process as we go, and then we'll figure that out in terms of whether we're going to transport or launch a plane without the CT angio done and then stand down, or what we're going to do. We'll have to sort that out. But if you can't get the CT angio up front, we're going to thrombolyse, and then we're going to see where the dust settles afterwards. All right, so in regards to advance notice, this CT tech received advance notice, and this CT tech did not receive advance notice. Okay, and this has been my personal experience, actually, because, at the U, and I'm sure at Foothills, those CT technologists, I mean, we do not give them donuts and, that fruit with the chocolate you can get from, I can't remember where it is, and they make it look like a nice design. We're not giving them enough of that stuff because they are so busy, and they accommodate us so much, and they try to drop stuff to do CT imaging as fast as they can. And the thing is, I mean, if you don't give them enough notice and it's, we got an acute stroke right now, it's outside the door, I mean, that doesn't go over well. They'll accommodate to it, but really we need to give them as much notice as possible, okay? So it's important to do. And they have a technologically complex job in terms of windowing CT angios and everything, so I think the notice is appreciated. All right, so as I mentioned in the first thing, most TPA decisions can be made on plain CT. We like to have a CT angio. There's a certain proportion of patients that are very diagnostically confusing. Like, for example, the patient with the seizure at onset that might have had focal symptoms prior, but you're not really sure from the history. And when you arrive, the seizures stop, but they're hemiplegic. And you're not sure about a hyperdense MCA sign because of the density of the MCAs on both sides. You're not really sure. If you saw a big blockage there, you'd probably thrombolyse that person for sure, right? So there are situations where the CT angio makes a difference. And if I had my ideal situation, I'd get it done in every patient prior to lysis, but that isn't often how it works. So we do the best we can. All right, so it looks like my slides have gotten mixed up a little bit. So we're just going to keep going here. And then the other question is CT angio required every time pre-thrombolysis? We just answered that question as well. And we want to do it as quickly as possible. All right. So I guess this is another question we've already answered, so this will be a quiz. All right, so Steve's plain CT scan's finished. The techs are able to do a CT angio. Should they wait until all the CTA images are post-processed before sending the CT and CT angio images to PACS in one big file? Who says no? Everybody by now. Great. That's perfect. Okay, so the answer is no. Acquire and push the axial plan images first, and then acquire and push the CT angio source images. And then if you can do the MIPS, fine, but the source images are what we look. We look at those axials, and we make decisions on transfer from those axials. Those are what we look at first off. And those are often the only scans we have on telestroke. At the time we have to make a transport decision, we often don't have the coronal and sagittal MIPS and all those other things, so we look at those axials right off the bat. Okay, so a couple of other questions. So what is this stretcher to CT business? And I think now we've also answered those questions a lot. So following the swarm, the patient goes to CT in the EMS stretcher without pausing much in the ED. And there's data from Foothill's DTN project that stretchers to CT can actually save up to 20 minutes. And there's other data in the literature that says the same thing. All right, and the next question is, will they be giving TPA in my CT scanner? And the answer is maybe. So at the University Hospital, we're struggling right now with stretcher to CT because, and we just actually got it formalized and implemented just like literally 2 weeks ago. And the reason we're struggling is because there's no place to really swarm in the front door entrance so we go to trauma to swarm. And then we want to thrombolyse on the CT scanner. So that's what we like to do. So what we do is we do the plain scans a lot of the time. We immediately mix TPA in the scanner. We give the bolus. We complete the CT angio, move the patient back, and continue the infusion within minutes back in the trauma bay. And this is our process that we've used. What we're finding is stretcher to CT is kind of pushing off the stroke fellow's NIH stroke scale. So we have to now, we have a fellow who hasn't examined the patient and they're on the CT scanner. And so then we can shoot a CT, but we have to move them back to trauma before we thrombolyse. So we're finding that we're struggling right now with the best way to use stretcher to CT. But most places across the province will benefit from a stretcher to CT. And in some situations, the next question is, will they be giving TPA in my CT scanner? Well, maybe. It all depends. I mean, if you go stretcher to CT in a primary stroke center, it's probably unlikely that you're thrombolysing in the scanner, right? Your CT scan's done. The images have to be pushed. The telestroke neurologist has to see them. I have to talk to the doctor by phone and then by video, and then we'll give TPA. All right, so you CT techs who don't want, who are nervous about TPA being given in your scan.